Hey, good afternoon. It's a pleasure to be speaking to you today. Have no conflicts of interest. What I thought I'd do is focus on two areas that I think there's some new information that is worth reviewing. And one is nevus to melanoma progression. I'm going to talk to you about. We are actively interested in delving in depth into this concept in my laboratory. And two, some of the new findings on the role of UV radiation during transformation. So for the residents, we do talk about melanocyte transformation, malignant transformation to melanoma. And one thing we should think for the moment, where the melanocytes located. Epidermal melanocytes on the skin, or interfollicular melanocytes. We have melanocytes at the hair follicles. We have melanocytes in the uveal tract. We have melanocytes in the palms and soles, melanocytes in the subungual areas. And studies have demonstrated over the years that these melanocytes may be different, and that the melanomas that arise from these melanocytes may be different. And so one concept is, in dermatology, we know that the majority of melanomas derive from de novo skin where there's no nevus or precursor lesion. And then another is the nevus or the dysplastic nevus progression to melanoma model. So I'm going to focus a little bit on this nevus to melanoma progression model. According to a number of clinical studies, there is a close link with nevi and melanoma. If we look at epidemiological studies, and these are very well done studies over the years that I'm referring to, not just one or two, melanocytic nevi are risk factors, meaning a single dysplastic nevus on the skin confers a twofold risk for melanoma. If you have more dysplastic nevi, and these could be clinically or histopathologically defined as dysplastic, but mostly these are clinically dysplastic nevi, 10 or more dysplastic nevi confer a 12-fold increased risk. So there's definitely this very solid information. So based on this information, a number of scientists have carried out GWAS, genome-wide association studies, to see if they could find a single nucleotide polymorphism that could be linked to this phenotype. So what they've done is, basically we're talking about hundreds of patients where the DNA is sequenced, and you have one group of cases with patients with lots of nevi, dysplastic nevi, patients with not very many nevi, and the concept is, can we find a SNP that is associated with this phenotype? What is shown through these GWAS studies, and similar thing has been done for melanoma. Cases with melanoma, cases no melanoma, are there SNPs? Patients with red hair, patients with no red hair. One thing that we learned, and it's solid, is the MC1R polymorphisms, melanocortin receptor 1 polymorphisms, are associated with red hair phenotype. That's very clear. There have been a number of publications looking and showing some of the SNPs in these genes I'm showing here that are solid, are not utilized, not validated, so I'm not sure of the validity of this as yet. It hasn't panned out as it has panned out for example, the MC1R variants association with red hair phenotype. So we're going to put this nevi as being risk factors and SNPs and the association aside for a moment, and then we'll go to nevi as precursors. So we clinicians know, and you pathologists know very well, that many times we would have a melanoma, and next to the melanoma would be either a clinical nevus that clinically we can sometimes identify, or you can identify better, where there are nests of cells that are clearly nevus-like cells. So melanoma arising from a pre-existing nevus. If we look at studies Again, well done histopathology studies, because clinically it's very hard for us clinicians. There are many, sometimes it's very clear that you can tell there's a nevus and the melanoma develops, especially if you do a lot of dermoscopy or photography over time. You might be able to see there was a nevus and then now there's a melanoma rising from it. But clinically may not be easy for us to pick up this, but pathologically a lot more. So these are nice, well-done histopathology studies showing 25% of melanomas with histologically associated nevi. This is a big number. It means 1 out of every 4 melanoma that we're seeing should be arising from a nevus. Now, I'll go into this a little bit more in depth. So I'm sure you would all agree with me. You've seen these cases. These are patients with what we would call typical classical dysplastic nevus syndrome patients, where they have clinically, most of them are dysplastic nevi. Histopathologically, you would characterize them as dysplastic. Another way of looking at it is some clinicians refer to these as individuals with many nevi. And whether these are patients with dysplastic nevus syndrome or patients with many nevi have definitely a higher risk for developing melanoma. And then here are individuals with what we call congenital melanocytic nevi. And typical classification is at birth, these individuals have these nevi present. It's not so much of an acquired phenomena. And what we also know is that the size, the load of the nevus associates with increased risk of malignancy. So a child with a giant congenital melanocytic nevus has a very high incidence of risk of developing melanoma. Usually these melanomas develop within the first 10 years of age. They are not necessarily obvious on the skin. There could be neurocutaneous melanosis. They could be developing in the deeper tissues. Very tough cases for us to manage. What do you do? Remove all skin melanocytes. They could be melanocytes in the deeper tissues. So I'm going to give you an example later on. Medium-sized congenital melanocytic nevi or small congenital melanocytic nevi have some risk, but much lower than the large congenital melanocytic nevi. So we have learned through lots of sequencing studies, next-gen sequencing studies, in terms of the major drivers or genetic drivers within these nevi and melanomas. We have learned that these are, I'm showing you some very standard common acquired nevi, compound or intradermal, or they could be junctional, and the majority, and we're talking about really 80–90% or so, have a BRAF activating mutation. Most of them are BRAF V600E mutations. And the congenital melanocytic nevi, the very typical congenital melanocytic nevi where you see it at birth, 80–90% or so, NRAS mutations. And blue nevi, GNAQ11 mutations, Spitz nevi tend to have HRAS mutations. Dysplastic nevi, we've done some studies, patients like this, most of the time you'll see BRAF, sometimes we see RAS mutation. And what we have learned over lots of scientific studies is that nevi can transform into melanoma, but you need other genetic events, most likely tumor suppressor loss, P16, P53, P10. This has been very well characterized over time. What I want to talk a little bit about what happens when we have a melanocyte that has a BRAF activating mutation or RAS activating mutation. There is a proliferative phase that these melanocytes proliferate. So when we look at the skin, you would see the nevi would form. They would be small, 1 millimeter, 2 millimeter, and then at 4 or 5 millimeter, they would stop growing. It doesn't progress beyond, meaning it doesn't transform into malignancy. But there's definitely melanocytic proliferation. And individuals have looked, lots of functional studies have done. The concept is that a tumor suppressive mechanism of our system kicks in, and that basically an oncogene-induced senescence machinery kicks in, and these nevi stops. So only you need other events so that you can bypass a BRAF or NRAS senescence event. So lots of active studies going on in this area. What we have learned through, this is a recent TCGA initiative led by Dr. Chen, published in Cell. When we look at melanomas, and these are 400 melanomas that have been sequenced, so we're looking at the DNA level. And I'm also, just to say, very glad that I'm in the melanoma field, not lymphoma. We keep classifications very simple. We have about 52% of these melanomas with a BRAF mutation. We have 28% melanomas with a RAS mutation, and small number, I think there's about 14 NF1, neurofibromatosis 1 gene. It's a tumor suppressor, negative regulator, the PI3 kinase. And then a fourth category called triple negative. You don't find any of these mutations. But BRAF and RAS mutations are typically not found together. They're mutually exclusive for the majority of cases, just because they activate the MAP kinase pathway, so no reason to have both. So let me just go to the next step. So just to point out to you that there are 4 major categories, and again, we're looking at similar to a BRAF-RAS clustering. That makes me think, is the concept of melanocytes transform without going through a nevus phase? Is that concept correct? It's just a question mark in our mind. We clearly need other tumor suppressor events. That's already proven. So I want to give you an example of this patient. Our derm resident, Dan, had this case, and he said, can you take a look at it? And pretty impressive case. A 46-year-old man born with a giant congenital melanocytic nevus presents to the hospital with shortness of breath. Pleural biopsy shows metastatic melanoma. So he is born with this nevus. This is a typical giant congenital melanocytic nevus. And let's examine a little bit. Here you have this big nevus, and its nevus stops here. You have another nevi. These congenital nevi typically have long hairs. And then these are all nevi satelloidosis. He has it in the axial side. He's pretty much everywhere. And I'm going to come back to this because we've sequenced this case a lot. PET scan of this case showed hypermetabolic process of the lung parenchyma, mediastinum, lytic bone lesions. MRI of the brain did not show a mass. So he has stage 4. He walks in with stage 4 disease. We can't find a primary. It's probably in the deeper component. And pleural biopsy and skin biopsy confirm metastatic melanoma. We carry out 50-gene panel, which Nina is going to talk about a little bit more. We pick up a RAS Q61K oncogenic mutation. So normally we would have predicted this mutation, but now we're confirming that this patient has RAS mutation. Obviously, we wouldn't put this patient on a BRAF inhibitor. He's started on immunotherapy. But this patient reminded me of color code defects, what we call color code defects, and it's been pretty well characterized in a lot of initial work in the 90s, 2000, when individual scientists looked at pigmentary pathway alterations. So if we think about where the melanocytes and melanoblasts arise, they arise from the neural crest melanoblasts, and they basically migrate through dorsolateral or ventral pathways. And here is mouse with a SOX10 mutation. These are loss of function mutations. MITF mutation would give you a similar phenotype. PAX3 would give you a similar phenotype. These are genes important for a pigmentation pathway. And they are also important for survival of these melanoblast melanocytes during the migration. So what happens is the melanocytes migrate and they're differentiating as they're migrating, but if there's a loss of function mutation, they can't come and give pigment to this area. So they migrate, but they stop here. This is called a white belly phenotype. These are loss of function mutations, so they're not able to pigment. Waardenburg syndrome, for example, clinically, we see this phenotype in patients identically. So go back to our patient. And I actually had Glenn Merluna from the NCI, who's a mouse modeling expert, was visiting. I showed him this case. I said, this is what I think. What do you think? And he confirmed. So this is what we think. So clearly, this is the opposite of the white belly phenotype. So here, he has normal skin as this. So his melanocytes have been able to migrate and pigment his skin entirely. There's no white belly, so there's no depigmentation, but he has a lot of pigmentation, a lot of melanocytic pigment genes proliferating, and then here, these are the satellites. So we think, this case, we sequenced it. He has everywhere. He has RAS mutations, but more analysis is being done. It's highly likely in the neural crest there is a subclone of melanocytes that are driven by the RAS mutation. Not so much. We don't think this case is going to have a germline mutation, but a subclone that gives this type of phenotype, and that's somatically driven. So again, think about this. I see a lot of these patients where they have lots of nevi, and go back for a moment. That remind me of these nevi where you don't have this big one, but many satellitoses, very symmetrical, and these are mostly BRAF driven. So it's possible that we have more like a somatic BRAF driven mutations that might be developmentally relevant. So this needs to be proven, obviously. We have also carried out a lot of sequencing of nevi, and this is going to be published. Again, we see these are dysplastic nevus patients. We see either BRAF or RAS mutations, mostly BRAF mutations. When we look at the numbers of mutations in nevi, nevi have low frequency of mutations as compared to melanoma, but they have UV mutation signature, which is going to make me switch to a little bit of giving you an update on UV radiation, what we've learned over the past year or two. Xeroderma pigmentosum, most of you know this clinical phenotype disease, first described in 1874. So we knew about the UV and melanoma link for decades and centuries, really. We knew that patients with xeroderma pigmentosum recessively inherited disorder have high risk for melanoma and lentiginous. These patients have 10,000-fold increased risk of skin cancer, including melanoma. Median age of skin cancer in these patients about age. So usually you wouldn't have a child with a lot of freckling unless they have a xeroderma pigmentosum phenotype. And you can see the sun-protected areas don't have any lentiginous. And it's very unusual at age 10 to develop a melanoma or a basal cell squamous cell. This is a condition, as we learn more in depth about this disease, we learn that these individuals have germline mutations in the nucleotide excision repair machinery. So this machinery is important to repair UV mutations. Whenever we're just walking around, it's a sunny day, we get a DNA lesion, a mutation, but our machinery repairs this effectively. If you do have a major a germline mutation where the genes coding for some of these critical proteins are not able to repair, you keep adding UV damage on top of one another. So this is a patient of mine, doesn't have xeroderma pigmentosum, is an adult case, 50 years old, likes the sun, goes to Florida and lays out in the sun. And these are some nevi, so you don't have to have XP to give this kind of phenotype. What have we learned through next generation sequencing about UV and melanoma? So this is a study published in Nature a couple of years ago, and many of these studies have been published right now, showing the same results. So it's solid data. They looked at somatic mutation frequencies across cancers. So we looked here 3,000 tumor normal pairs. And here are the somatic mutation frequencies reported per MB, a little bit easier to report. For example, childhood tumors, AML, they have a medulloblastoma, get about 1 mutation per MB. If you look at breast, we have breast cancer, it's about 10 mutations per MB. Let's take a look. We have pancreas, about the same, ovarian. Now, if we go all the way far right, the cancer that has the highest mutation load is melanoma, hundreds of mutations per MB in melanoma. and that equates to 1,000 mutations in a tumor. Second to melanoma is lung cancer. Again, it's pretty high up. So one thought is two cancers that has the highest mutation rate that are associated with environmental carcinogenesis. One UV, the other is with smoking. What they also looked at nucleotide at the nucleotide level, and they looked to see C-to-T transition enrichment. If you have a C-to-T mutations, this is indicative of UV signature. So if you just follow the yellow here, as you can see, right all the way on the right, melanoma has the highest C-to-T mutation. So it's now we have more genetic evidence of UV mutation and mutational load in melanoma, somewhat confirming our original clinical findings or observations. So again, in melanoma, we would like to keep the classification very simple. We talk about cutaneous melanomas arising from epidermal melanocytes, follicular melanocytes, mostly driven by BRAF or RAS mutations. Acral melanomas rising from palm, soul, subungual sites. They tend to have either KIT mutations or amplifications. They can have BRAF, RAS mutations, but there's a big, like about 15 to 20% frequency of KIT mutations or amplification in acral melanoma. If you just look at cutaneous melanomas, you would only pick up about 3% KIT mutation frequency in this group. Uveal melanomas, GNAQ11 mutations, BAT1 deletion. Again, mucosal melanoma, enrichment of KIT mutations is about 15-20%. What we've learned again is if we sequence melanomas from sun-exposed sites, the mutation load is high. In this paper, 171 mutations per tumor, and then in sun-shielded areas, it's about 9. So definitely there's nice correlation that we're showing that mutation load correlates with sun exposure characteristics. I'm going to briefly go over our sun exposure behavior over the past century or two. So it's thought that our sun exposure behavior changes in the 1920s, 30s, and Coco Chanel, a French designer, has significant influence in our behavior. I like her fashion. A milky skin seemed a sure sign of aristocracy. So this is 1800s, early 1900s. If you look at books, movies, women are covered head to toe in a way. That's the fashion. They have a hat. They have an umbrella when they go out. You don't see women with a tan. It was only the workers outside were allowed to have a tan in a way. So this was the type of look. They didn't go to the beach, vacations. This is 1800s, early 1900s. Chanel, she's a very influential person, getting very successful in her business. Women try to do whatever she does. So she's smoking. They don't know the exposure of smoking, the risks of smoking at the time. Women start smoking. She has an active social life, and she's spending a lot of time in yachts. She works out with a tan, so she's gets her Chanel No. 5 perfume out. Women start tanning. According to history, not sure how it is, but she seemed like she influenced somewhat. The look of having a suntan was okay. It was not necessarily, it was okay to have a look like that. Claude Monet, and you can see the behavior here, sun behavior. We have a hat, long dresses. We have an umbrella. Early 1900s, the sun exposure behavior changes. We start going to the beach. And we lose the hats. We're at the beach more and more. Cancer statistics just published, American Cancer Society. Melanoma of the skin. This is from 1975 to 2011. This is in men. It's steadily increasing. This is the incidence. What we also know is, unfortunately, mortality in men is increasing as well. And this is a problem. We're trying to educate men how to prevent skin cancer. Women also increasing, but the really biggest increases in men, especially in terms of the mortality rate. If you look at bladder, it's pretty stable, going down. Lung going down here. Unfortunately, lung cancer is going on in women. And I took a few notes from the American Cancer Society's report. So currently, cancer is the second leading cause of death in the U.S. It is expected to surpass heart disease as the leading cause of death in the next few years. We have a total of 1.6 million new cancer cases, about 589 cancer deaths, melanoma deaths that are about 7 to 80,000 in the United States. So cancer, the incidence frequency is about equivalent to 4,500 new cancer diagnoses each day. And this is of interest. About 60,000 cases of female breast carcinoma in situ and 63,000 cases of melanoma in situ or diagnosis. So melanoma in situ is catching up, unfortunately, with breast in situ. Skin cancer is the most common cancer. I'm going to stop here. Thank you.